Thanks, Carl. So I've been asked to speak about, is EBM broken? Kind of weird question. And let's get this clear. I think the question is not, is EBM real or rubbish for all time? But when we're talking about the management of an individual patient, you know, I am a practicing doctor. When we're talking about that, in this patient, in these circumstances, is the management an appropriate, that is real, or an inappropriate, that is rubbish, application of the principles of EBM? The big issue in evidence-based practice, I think, for the last 15 or 20 years has been lack of individualization. And this was summed up back in 1999 in a great article by Mark Tonelli called The Philosophical Limits of EBM. And he said, in EBM, the individuality of patients tends to be devalued. The focus of clinical practice is subtly shifted away from the care of individuals toward the care of populations. And the complex nature of sound clinical judgment is not fully appreciated. And I mean, people have been talking about this for a long time, but I want now to talk, as Carl said and Fee Godley said earlier, we want to really focus on solutions. And the solution, I think, is to shift away from looking at the evidence and think, how can we implement this, and start looking in detail at real clinical cases, and then start thinking how the evidence might apply in those cases. I think there have been three phases in EBM's claims. If you don't know what the word epistemological means, don't worry about it, just leave it out. The first phase, which didn't last very long, was the claim that epidemiological evidence would routinely trump intuition, clinical judgment, anything, you know, all that soft stuff that might come from the clinician. That didn't last long because people very quickly realized that epidemiological evidence was just one component of the evidence we need when managing patients. We also need clinical judgment. We also need a lens on the patient perspective. And this was all to be integrated, although they didn't at the time tell us how. It was a sort of black box. More recently, it has become quite fashionable to talk about precision medicine, individualizing epidemiology through doing large trials with prospective subgroups, all sorts of patients with different kinds of comorbidities, so that at some point in the future, when we stacked up all this evidence, the patient will come in and we'll be able to kind of look through our virtual filing system and find just the right subgroup analysis that fits Mrs. Bloggs' problem. I don't think precision medicine is going to go anywhere, personally, because I just think we're going to have what I would call the problem of repeated decomposition. There's always going to be subgroups within subgroups, contingencies within contingencies, and in the end, the only person that is exactly like Mrs. Bloggs is Mrs. Bloggs. So I think we need to go back a bit to this middle bit and talk about how are we going to integrate these different kinds of evidence. We've got epidemiological evidence, the trials and observational studies. We've got clinical judgment, which is things like tacit knowledge, practical wisdom, mind lines. All these have come up quite a lot in the last couple of days. And, of course, the patient's perspective, which is not just about shared decision-making tools. It's also about all those aspects of good consulting that we teach the students about active listening, etc., etc. So how do we integrate all those? I remember many years ago, and it must be 20 years ago, Dave Sackett standing up in a conference in Oxford and encouraging us as clinicians to ask this question: were the patients in this trial sufficiently similar to the patient in front of me in whatever key respects that I can safely apply the findings to this case? And Sackett added, if not, piss on it. And what he meant by that was reject that evidence because it isn't going to do you any good. I would come from a slightly different perspective because I'm not a trained epidemiologist. I'm a frontline GP, but it's really the same question. I would say where we start is the question of what do I know about this patient, her history, the findings from examining her, her test results, how she reacted last time she took this drug or had the operation or whatever, her beliefs, family circumstances, and all that kind of thing. Given the totality of that patient-based evidence, what research evidence do I need? So patient-based evidence is not just about patient preferences, it's not just about the subjective narrative, important though that is, it is the totality of what's going on with the patient, and I don't think we use it enough. And I'm going to demonstrate that to you with a real case. In the Journal of Evaluation in Clinical Practice recently, there have been 2 papers published around sort of expert judgment, expert opinion, interpretation. And I read those with interest. I tweeted about them a couple of weeks ago. But actually, I don't think they're saying very much more than I was saying in the BMJ back in 1999, and Catherine Montgomery was saying in this truly brilliant book that was published in 2005. In fact, I think it was the second edition that came out in 2005. Now, and we were quoting other people who'd previously published, but certainly one of those articles spends quite a lot of the time unpacking an example that I gave in 1999, and I was quoting back from, I think it was Nigel Stott. So this stuff has been around for a while. So what were we saying? I'm actually going to sort of distill it into a rather nice sequence of phases, which Engbretson et al. Came up with, and they were following a philosopher called Lonergan. So the varifocal's not very good at that. And Lonergan, cited by Engbretson et al., talk about the practice of doing medicine. I mean, Aristotle was writing about this as well, or speaking about it, many centuries ago. Medicine is a practice. And what they were doing was unpacking what that practice actually is. And the first phase in that practice, I know you guys like phases, was collecting sensations and observations, something that calls for explanation. Now, it might be the patient's sensations, the symptoms, or it might be what I sense when I put my stethoscope on the chest, and it's also, of course, the test results, etc., etc. And that gives us data. The next phase is interpreting those data, asking the question, what could this be? Any of you who have been qualified as a clinician for more than one day will know that the test result doesn't tell you what's wrong with the patient. You have to interpret that result. Is this really significant or isn't it? And that leads to understanding. But even when you've got your various interpretations, you might interpret this test result in one way, someone else might interpret it another day. You've got to weigh up those different interpretations in a judgment. And then you've got to decide what to do, choosing how to act. And this is fundamentally an ethical decision. What's the right thing to do? And for that, you need deliberation, and often deliberation among the multidisciplinary team. So that's just beginning to get an unpacking of how we integrate these different forms of evidence. Now I'm going to give you a case example, and people have been saying to me today, "Oh, you've had a difficult year, haven't you? How's your neck? How's your, whatever?" So I thought I'd use myself as a case. I would say that although I'm going to challenge and in fact directly criticize some of the management that I had, this is not intended as a complaint against people who were managing me. This is intended as a fairly in-depth discussion of a case to ask, what can we learn from this? What can we learn about evidence-based medicine? What can we learn about the use of guidelines? Because I was certainly managed according to guidelines. Those of you who follow me on Twitter might have seen this tweet. I certainly got, quite a few dozens of replies when I tweeted that I'd fallen off my bike. I was in hospital with 2 broken arms and I was on the trauma list. I tweeted lots of pictures of my bruises. I tweeted pictures of me being patched up by nice, happy nurses. I tweeted pictures of my physiotherapy. And finally, a month after it all, I was feeling quite a bit better. So that was my case. Let's start off then, as I think we should always start off by having a history from the patient, the subjective narrative. I was riding my racing bike along the towpath. I was going about 20 miles an hour. It's a bright sunny day. Something got caught in my front wheel. Perhaps it was pushed, but perhaps it just rolled in. The whole bike went up in the air and somersaulted, and I came down very heavily on concrete, landing on my arms and also on the back of my head. very dazed, but I don't think I was knocked out. Both my arms were deformed and completely useless, and I had marked numbness in the fingers of my hands, and my helmet was split. This history was distilled into a couple of sentences from a junior doctor. On the ward round the next day, 55-year-old female fell off bike, and I was channeled into the falls algorithm. Now, the irony of that is, when I fell off the bike, I was only 54. But by the time the ward round came round 2 days later, I had met the criteria for being in the evidence-based guidelines for falls prevention, which happens the day you turn 55, which unfortunately was the day that I was in there. And so, this is actually from the CDC in America, and actually the particular falls prevention guideline that was used on me was not this one, but it was one remarkably similar. And I can report that what happens when you're lying in hospital bed, wondering how you're going to eat the food that they've put on the trolley in front of you because your arms don't work, you get a nice lady coming in wearing a white coat and with a clipboard, and the first question she asks you is, "Can you hear me?" And I was offered a home visit to make sure that the rugs were taped down and that there was a rail to help me get out of the bath and all that kind of thing, which I politely declined. Now, I hope you can see the mismatch between the narrative here and the guideline that I found myself channeled into. Although I met the criteria, I was a 55-year-old female who had had a fall. Let me give you now some more objective data on what happened. I had, over the next 4 months, 7 operations to put the bits of bone back, put in metal, get metal out. The numbness in the fingers persisted, and I went along to outpatients and was reassured by a very confident junior doctor, "Look, dear, you did break your arms. You will expect to have numb fingers." At 6 months, I had another review, actually with another doctor at another hospital. I decided to change by then. I had wasting of the muscles in both hands and was also noted to have heaviness, clumsiness, and hyperreflexia in the legs, including quite marked ankle clonus, which was shown to the medical students. No one was more surprised than me. I was sent off for an MRI scan, which showed severe cervical disc prolapse at 2 levels and 2 collapsed vertebrae. Now, we will never know whether those vertebrae were fractured at the time of the bike crash or whether they collapsed subsequent to the disc prolapse. I went along and had a very successful cervical disc replacement at 2 levels. Here is another guideline. This is the NICE guideline for selection of adults for imaging of the cervical spine. Adults presenting to the emergency department who have sustained a head injury. Now, my helmet was split, so I think I definitely came down on my head. But look at the criteria here. Dangerous mechanism of injury, fall from greater than 1 meter or 5 stairs. Well, I can tell you I was right up in the air and flipped out, so definitely more. And an interesting piece of this, ejection from motor vehicle. Well, my vehicle wasn't motorized, but I was certainly motoring along, and I was ejected. Now, it's a very good example, I think, of the interpretation of the guideline. Well, hang on a minute, it didn't have an engine, so it doesn't count as an ejection. Or would you, when you were looking at that guideline, think, it'd be a good idea to x-ray this patient's cervical spine? The learning point here is it takes judgment to decide which guideline to follow and how to follow it. An over 55-year-old female with a fall may also be an athlete with a high-impact hyperflexion injury of the cervical spine. I would encourage you to get hold of this interesting book by Bowker and Starr. One of the chapters in that book, they take apart, I think what was then the ICD-9 is now the ICD-10, that's probably the 11 by now, International Classification of Diseases. And what they say is we create classification schemes. Another classification scheme is, old ladies. Well, old ladies is over 55, and once you're in that, Once these classification schemes become enshrined in guidelines and protocols, they ossify and reproduce our assumptions and prejudices. Furthermore, it makes those assumptions and prejudices appear scientific. And Bowker and Starr demonstrate that by creating these categories, we then channel our prejudices in particular directions. And it's quite hard to then draw back from them. There are at least 3 people at this conference, and I'm really sorry to these people because they're kind of my friends as well, but I'm sorry, I'm going to use you as an example, who said to me, hang on, you didn't need that operation. There's been randomized trials that have shown that in cervical disc lesions, the surgical groups didn't do any better. So really, you shouldn't have had that operation. They said that without taking a history, without finding out what the examination showed, without looking at the MRI findings, and without acknowledging what the inclusion or exclusion criteria were for the trials. And it's a good job they did, because I think it's a great example of rubbish EBM. Sorry, guys. Let's have a look at those trials. Here's one. Surgery versus non-surgery in cervical radiculopathy, which is what I had. Prospective, randomized, ticks the methodological boxes, and it showed that initially the surgical patients did better, but then after 2 years, the medically treated patients caught up with them, so why bother having the operation in the first place? And so it says structured physiotherapy should be tried before surgery is chosen. But look at the exclusion criteria. Obvious myelopathy, slight intermittent signs of myelopathy, even in the absence of objective findings. A history of neck distortion. So those who were saying, and these patients hadn't had any physiotherapy. I'd had 4 months of physiotherapy. So wait a minute, guys. This, I think, is a classic example of the use of evidence. This is Grimley Evans. You must know this quote. In the manner of the fabled drunkard who searched under the street lamp for his door key because that's where the light was, even though he'd dropped the key somewhere else. And again, Grimley Evans was writing that in the 1990s. We do it too much. Let's go on. So having decided that my operation was actually going to be evidence-based, this is my kind of jugular vein and carotid artery we're talking about. I did look up the evidence before I signed the consent form. The surgeon advised me not to take non-steroidal anti-inflammatories for a month following surgery because he said there's some evidence of delayed healing of the bone repair and the risk of bleeding is higher in the post-op period. So this was a very simple question for me. I don't want to bleed, I don't want delayed healing, but I don't fancy going around in pain. People who've had this operation, it's pretty painful, for a few weeks afterwards. So of course I got onto Twitter. It's great, you should join Twitter, it's absolutely fantastic. So this is me, and speaking as a patient, I didn't tell them that, but whatever. So somebody tweets back, and this is a really good example of this rubbish EBM coming from the EBM community. Well, if you're not worried about the evidence for disc replacement, don't worry about the non-steroidals. But he also says, actually the evidence is pretty weak, the evidence on healing, blah, blah, blah. Other people were saying, no, I routinely prescribe non-steroidals after a discectomy. Very good painkillers, opioid sparing, they get you up and about. There's good reasons. This is, again, interpretation of the evidence. And I liked this one. This one really did make me think. This is someone I'm not sure who this person is. Lumbar discs, yes, take non-steroidals. Cervical discs, that ACDF, anterior cervical discectomy infusion, not in the first 24 hours, because when and if they bleed, the airway is often compromised. So suddenly, it's not very likely that you're going to bleed, but if you do, it might be catastrophic. So this is kind of scary. So I started looking up the evidence, and I'm not going to give you very many of these, because there are dozens and dozens of these studies. This is just one of many. Look at the pink bits. This is an animal study where they go in, they take rats, and they deliberately break their legs, and then they put some on non-steroidal and some not. And sure enough, if you treat rats like that, and you put them on non-steroids, they have delayed healing. Then there's sort of retrospective case-controlled studies of patients with a different kind of fracture who have had non-union. Looking back, they're more likely to have taken non-steroidals. Loads of studies like that. Okay, let's get a decent systematic review. I love this conclusion in the systematic review. What does it say? Animal and in vitro studies present such conflicting data that even studies with identical parameters have opposing results. So the evidence is an absolute mess. But they say, well, in the absence of better evidence, you're probably better off not prescribing non-steroidals, blah, blah, blah. All right, let's have a more up-to-date systematic review. And they go back and they simply say more research is needed. So this isn't getting us very far. We've got this mountain of evidence, which is methodologically flawed, it's small, it's underpowered, it's goodness knows what. What do I do? And this is the point I want to make. So many people then conclude we need to start all over again with another enormous trial. But let me show you what happens. If you take a more detailed analysis of the patient in front of you. So what we've got here is the objective evidence. Non-steroidals inhibit the same kind of prostaglandins that are involved in bone healing. Animals given non-steroidals showed slower healing of induced fractures. People with delayed healing were more likely to have taken non-steroids. This is all pretty low down the hierarchy of evidence. In randomized trials, post-surgical patients had a higher incidence of GI bleeding. So that's the objective evidence. We know that. We know that. Now let's look at the individualized evidence about this particular patient. So the first thing about this patient is that I am an ex-elite athlete. Anyone who's done sport at any kind of level knows that your coach is paid to train you to within an inch of your life and then to fill you up with non-steroidals to cover the pain in your recovery period so that you can get up the next day and do even more training. I've taken non-steroidals for 30-odd years, never had any problems with them. So that's the first bit of evidence. Second bit of evidence is that as part of my sports obsession, I think I'd call it, when I was younger, I had several stress fractures, all of which healed very quickly indeed on non-steroidals, and in fact healed rather more quickly than I was led to believe would be the natural history. So people would say you're going to be off your sport for 6 weeks. I was only off for 3 weeks. So for me personally, non-steroidals do not appear to delay my bone healing. I don't know about you, but for me, and we do know that with some confidence, this patient has had adverse reactions to opioids in a dose-dependent way. So for this patient, the option of jacking up the opioid dose isn't an option. This patient has had a particularly difficult operation. The surgeon came in quite late at night after the operation, was absolutely exhausted, was going to go home to bed, had cancelled his evening thing because the whole operation had taken several hours, and he said this was a very, very difficult operation. You will probably be in considerable pain. So I said, well, I already am in considerable pain. And I think Fee's in the room. I'd had a phone call from Tony Delamoth. This was Monday, and I had a phone call from him saying, look, if you're off sick with that operation, could you just do us an editorial and get it to me by Friday? So that had to be, that had to be, there she is. And I did. In conclusion, in this particular patient, it's all much easier now, isn't it? Now that we know this patient-based evidence, given the history, given the clinical picture, and given the equivocal nature of the evidence, the benefit-harm balance appears to be in favour of non-steroidals, especially after the first 24 hours. So I, in consultation with my surgeon, said, all right, I'll stick it out for 24 hours, and then I'm going to go on non-steroidals, which I did, and I healed absolutely fine. So let me conclude. This is the uncontroversial conclusion. I think it's uncontroversial. Whenever managing a patient, ask yourself, is my management of this patient in these circumstances an appropriate or an inappropriate application of the principles of EBM? I also think it's fairly uncontroversial and quite important that EBM experts, most people in this room have probably called themselves that, should avoid pulling rank on experienced clinicians by citing irrelevant randomized trials out of context where they don't know the patient. And I mean that very, very seriously. But here's a more controversial and I think more interesting conclusion. If we practice patient-focused individualization of the evidence, that is real EBM, we will often find that more research is not needed. Perhaps the uncertainty in science is inherent. And this is a philosophical point. perhaps we need to return a bit more to old-fashioned clinical method and use EBM slightly less comprehensively. Iona's cheering. Thank you for your attention. This afternoon, in the Real versus Rubbish EBM Part 2, I'm going to be talking about the biases within EBM against the patient. Just put a flag up for that. So thank you for listening. Let's take questions.
Yeah, I'll take one or two. You want to come on in down, and there's a few seats around here. We've got time for one or two questions, I perceive. Yeah, we'll go with this gentleman. Have we got a microphone?
Kit Barrett, I'm a geriatrician in Hereford. First of all, Lonergan's model effectively is SOAP, subjective, objective.
Can't hear you.
Sorry, Lonergan's model, I've just realised, is effectively the SOAP paradigm that we use for subjective.
It's not bad, is it? Subjective, objective,
assessment
and plan.
Which is very useful in clinical medicine. But the question was, I suspect that one of the problems is that a lot of the stuff comes from secondary care, and I think there's some, I don't think it's anecdotal or true evidence that that people who can't cope with uncertainty go into secondary care, people who can cope with uncertainty go into primary care or learn how to do it. So I think there's a systematic bias to try and make evidence more important to help people who can't cope with uncertainty deal with the world.
I don't know. Did you all hear that? The idea that people who can't cope with uncertainty go into secondary care because everything's much more rational and logical, whereas those of us in primary care, because we're very good at coping with uncertainty. Well, I'm not sure, actually, because I read somewhere, and I can't give you chapter and verse, that in a medical outpatient clinic, you've got as many patients with, complex, fuzzy issues as you have in general practice.
I think in the ology, I'm talking about the ologies, not geriatric medicine or paediatrics where you have to do everything. But I think, it's a generalisation, and I'm overstating the case. Yeah. But I suspect that there is some truth in that dealing with we're not taught how to deal with uncertainty in secondary care as in primary care you are.
We're not taught how to deal with uncertainty, I absolutely agree. And my strong feeling is that we need to shift our focus away from the evidence and how we're going to implement it to the patient and how we're going to cope with the uncertainties and contingencies in this particular case. And the more we reflect on that, the better we're going to be at applying judgment in selecting and applying our guidelines.
Okay, we've just got one more here. This gentleman here.
Stacia, Canada. Spellbinding presentation. One of the points that I would suggest may be responsible for rubbish EBM is that workshops given by EBM experts, and I have experienced both in Canada of several workshops over the last 15 years that are stereotypical still. And I'm sorry, Dr. Hennigan, I attended one here 3 years ago hoping it would be different, and it was as authoritarian as on the other side of the pond. And I think what is happening is that we are training the young minds to boxed-in thinking.
Yep.
They are not thinking outside the box.
We're
so we have lost
the young minds to boxed-in thinking. That's got to be, someone tweet that, please.
And I think that needs to be corrected, and we included that in our review as a challenge to these EBM experts who have done that. Thank you.
I couldn't agree more, and I think one of the problems in the training of the young, and I speak as the parent of a medical student here, is that so much of the learning now is on simulated patients. Stories that have been told in order to create a channel in which the evidence-based guideline pops up halfway through the case. I think we should be teaching students and young doctors and all of us on real cases, because it's only with the real cases that we get to this sort of judgment issue. With a fake case, there isn't a real judgment, is there? Because it's been made up. Anyway, I shall vacate.
Okay, thanks, Trish. We're going to move on at that point.